Good afternoon, everyone. I'm Madeline Johnson, a reporter at 360DX, and I'll be your moderator today. The title of today's webinar is Advancing Neonatal Care Through Rapid Genome Sequencing, and it's sponsored by GeneDx. Our speaker is Pankaj Agrawal, Physician-in-Chief at Holtz Children's Hospital and Chief of Neonatology at the University of Miami Miller School of Medicine and Jackson Health System.
Thank you, Madeline. Thank you, everyone, for joining. Good afternoon. So I'm going to talk about how we can implement genomics in neonatal care, and we are going to cover a lot of ground here. We're going to talk about reviewing the clinical relevance and impact of rapid genome sequencing in the care of neonates. We're going to try to address what are the right patients who can benefit from this testing. We can look at the diagnostic. We're going to look at the diagnostic yield. How can we implement genomics in the NICUs? And then explore some real examples just to make you familiar with. As a neonatologist, I have seen many cases where sequencing has helped them. So I'll talk about some of the case. The first case I'm going to talk about as a starter is a baby who was born, a full-term baby, was born at 41 weeks gestation to a 23-year-old mom, primi gravida with normal Apgars. Normal delivery, went to the regular nursery with the mom, but was noted to have some pallor, some hypotonia, and some poor feeding. So for further workup, baby was transferred to the NICU, had a full workup, including 48-hour rule-out sepsis, had cultures sent, which were all negative, had a normal head ultrasound, had a chest x-ray, echocardiogram, did fail hearing screen, and then they also did MRI, showed some subtle changes, like some mild abnormal T2 prolongation, some immature chiral folding pattern, and then a small lactate peak in the right basal ganglia. So overall, nothing diagnostic, some subtle findings. Then neurology, genetics were involved. They did their own testing, including microarray, which was all back as negative. So child gradually looked better, and then they started her on caffeine. She passed CAR-C test and was sent home on caffeine and an oxygen saturation monitor. Unfortunately, 3 days after going home, she developed several episodes of apnea and was suspected to have seizures, for which was readmitted, this time to a different hospital, a children's hospital, and was noted to have multifocal seizures, which were treated with phenobarb. Had, again, this time MRI was much worse, and MRS also showed this increased lactate peak. Again, a slew of tests, everything came back negative. So those days we were just doing this research study on the role of rapid whole exome sequencing. So the family willingly participated in this trial. And we also did a skin biopsy just in case we cultured the fibroblast and saved them. So the family decided to redirect care towards comfort care only and had an autopsy, which was, again, some subtle findings, but nothing diagnostic. And the family, as you can see, she was only 23-year-old. She wanted to have more kids. So she wanted to know what's going on. And because we had enrolled the baby in our study, we did rapid exome sequencing. And we found that the child, in fact, had two variants in a gene called HIBCH. It's a mitochondrial enzyme. One of the variant was pathogenic. One was a VUS or variant of unknown significance. There was a lot of discrepancy between the metabolic team and neurology and other teams, like what does it really mean because of a VUS? And her presentation was not consistent with what normally we see. For example, in these babies who have this condition, they usually have C4OH levels are elevated, but in her, they were not elevated. And then the disease was much more severe in her. So a lot of difference of opinion, but when luckily we had saved fibroblasts, and those were sent for HIBCH activity to a lab in Europe, and that came back as the child was severely deficient in HIBCH activity, confirming the diagnosis. And they used this information for pre-implantation genetic diagnosis, and now have two healthy boys and a healthy girl. And they have been doing some fundraising to help families with similar issues to get the chance of getting this rapid whole genome sequencing to other families. So they have been supporters for us. And this is just one example how critical it is to use this technology in neonatal care. So by one estimate or several estimates, about 10 to 20% of NICU admissions are likely because of genetic disorders. And many infants undergo diagnostic odyssey, which is long, difficult, costly, and it's a lot of time is spent without a diagnosis. And then selecting an appropriate test can be challenging too. And I'm going to talk more about that. We also know that infants with genetic disorders often experience high risk of mortality. They also need more resources, and they also have prolonged hospital stay. So what is the right genetic test for NICU infants? So if you look at the history, we started with karyotype many decades back. We still use it occasionally, for example, for Robertsonian translocation in trisomy 21. FISH used again for occasional cases with confirmation of trisomy 18 or 21. Microarray used quite often for newborns with multiple anomalies. And then there can be targeted analysis, single gene sequencing. There can be deletion duplication analysis, methylation analysis, for example, for Prader-Willi syndrome. And then a lot of places use multi-gene panel, for example, in newborns with suspected Noonan syndrome. But more and more, we are pushing that we should use exome or genome sequencing, especially rapid, as the first line test. So this was my experience when I started fellowship, that when a baby is born and is floppy, you go through all these different testing, $1 million workup, as we called it, and it took months and months before we could even reach to a diagnosis. And now we can get a diagnosis in 3 to 5 days and without going through all this extensive testing. So there's a big sea change in the care of babies with, for example, those who are born floppy. So we did a study ourselves where we enrolled NICU babies during 2017-18. We enrolled NICU babies within a week of admission, and we analyzed trio exome within 5 days. And we came up with certain inclusion criteria like unexplained hypotonia, seizures, multiple anomalies, metabolic disorders, or some other conditions where we thought this may be of use. We approached 57 families, 52 families agreed to participate, and then 2 of them backed out, but we had sequenced 50 of them. We got a definitive diagnosis of 58%, and then remaining were used for reanalysis. It helped the families in many ways, and one of the families I talked about early was part of this study. So some of them directly benefited. One infant with SCN2A mutation was more responsive to phenytoin. There was an infant born with MTM mutation that was eligible for a gene therapy trial. And then there was referral to additional specialists, big help to reproductive decision-making for many families. Many infants could go for a tracheostomy or a G-tube as we got the diagnosis a lot faster. And in at least one case, we could provide early comfort care because of the devastating outcome associated with their genetic condition. So this just shows the extent of management implications that can be associated with the diagnostic finding. So we propose that every infant who is in the NICU who can have a potential genetic disorder should have a rapid exome or genome sequencing. And there are many studies, and they're outlined below, which we have seen that diagnostic yields can be ranging from 20 to 60%. It decreases the time to diagnosis, and it can have significant impact on neonatal care. And its high utility has been perceived by many clinicians and parents, and is cost effective. These are some of the studies that have been published over the years, and this is not a complete list. There is more studies, but it just shows that of the 1,601 patients, 37% got a diagnosis. There was a utility in 28% and a change in outcome in 16%. Again, this is not a comprehensive study. These are all different studies from all different parts of the world. Again, more and more the societies like ACMG, National Society of Genetic Counselors, and American Epilepsy Society are recommending that genome should be used as a first-line test in conditions as described here for patients with one or more congenital anomalies less than 1 year of age, or patients with developmental delay or intellectual disability, before the age of 18, or all individuals with unexplained epilepsy. And this is a study we did where we showed that babies with unexplained hypotonia should undergo exome or genome as a first-line test. So who's the right patient for rapid exome or genome in the NICU? So we came up with a list of conditions, excuse me, which we thought will be relevant. Again, this is not a comprehensive list, but and then there is another list which is even bigger and more detailed that talks about all the different conditions where genome sequencing can be beneficial in early diagnosis. So the other approach is that we have so far talked about inclusion criteria. How about exclusion? Like sequence every baby who comes to the NICU except for those who are like in this study, like Seq-First study that was done at Seattle Children's and was recently published. They showed that they, instead of using inclusion criteria, they used exclusion criteria. They excluded those who were more than 6 months or diagnosed with a genetic condition, or they had history of physical trauma or infections or complications of prematurity. So they found that 49% of those infants who were in the intervention group had a diagnosis versus only 10% who were in the control group. So clearly a major advantage of getting rapid sequencing in the intervention group. And 42% of those who were diagnosed would have been missed if they went with a standard approach. So that's a big number. And overall, they summarized the study that up to 9 times more likely to receive a genetic diagnosis if we go with broad testing protocol versus conventional approach. And as shown here, the rate of diagnosis was 49.2% for that can explain, fully explain, or likely explain, or partially explain. And 29% had a fully explained disease. So that's, again, that matches with most of the studies that have shown around that range, 30 to 40% can have a real answer by this approach. This just shows how much success based on the type of disorder. For example, if there were 2 kids with hematologic abnormality, 100% of them had a diagnosis. Multiple anomalies, 53%. Isolated anomaly, 33%. Seizures, 55%. Organ failure, 34%. And then others, 72%. So it's all over the place, but it looks like there are some conditions which are more likely to be diagnosed by this test. Then what is the impact? And we already talked about that. We can have early diagnosis. It can change medical management. It can reduce healthcare costs in a big way. They can reduce the length of stay in the NICU. They can avoid invasive procedures. We can also, really make a meaningful medical change. For example, avoiding tests, treatment changes and all. And 42% of critically ill admissions don't receive a diagnosis. So that's a big number as we showed in the previous study. So there are over 800 NICUs in the US and 400,000 at newborn admissions. So there is a big need for this test to become available in the NICUs all across US and likely around the world. This is one example of a condition. I don't know if you've seen it, but I've seen a few cases where they were diagnosed with colonic atresia, multiple colonic atresia, and then either if they were tested for a genetic condition, they were found to have this heterozygous variant in a gene called TTC7A, which is also associated with hypogammaglobulinemia and decreased T cell function. And these patients can benefit from IgG replacement, pentamidine, PCP prophylaxis, and then Synagis. This is another example. This is example. Typically, we don't use genome sequencing or any sequencing. This is an infant who had intraventricular bleed, needing multiple transfusions, and they could not measure the levels, factor 8 or 9 levels, because of repeated transfusions. But sequencing provided a pathogenic variant in F9 gene, so that immediately changed the management by using this recombinant factor 9 concentrate instead of fresh fluorescent plasma or other approaches. This is another example of where diagnosis really changed the course of care of this patient who was a full-term baby with jaundice, pale stools, elevated bilirubin, some other findings, was noted to have JAG1 variant, where the child was typically gone for a Kasai procedure and would have really had a poor outcome if they did Kasai. So this was prevented. And that's another benefit where you can prevent a procedure or you can do a procedure. There are many different ways that medical management can change based on the genetic diagnosis. And there are also clear cost-saving advantages from this approach. This is a baby bear study from California, where they had a diagnostic yield of 40%, and they changed management 32%, and cost saving typically $12,000 to $15,000. And the cost at that time was $9,500 for a rapid genome, and nowadays it is $3,500 to $4,000. So I think the cost saving is even bigger now, and it will probably shrink over time even more. And these are, again, some examples of real conditions where, like, you can either give a treatment which can directly respond, the child can directly respond to. For example, I've seen cases of PNPO mutations where they respond to supplemental pyridoxal 5-phosphate or other FOLR1 with folinic acid. And then other ways where you can change or you can treat with the right anti-epileptic drug or ketogenic diet, where knowing the diagnosis, knowing the genetic condition or a genetic variant can help in the management. Similarly, there can also be examples of where bone marrow transplant can help, and these are some of the conditions which are genetic conditions where bone marrow transplant can be curative. So unless we have the diagnosis, we cannot approach with a bone marrow transplant. So we are doing our own study where we are looking into implementing genomics in resource-constrained NICU. So this is, as you know, about a majority of the NICUs don't have the expertise of a geneticist or a genetic counselor, and they do have to deal with a lot of cases with various genetic conditions. So we came up with this study, which we call VIGOR, which is Virtual Genome Center for Infant Health. And it provides free rapid genome sequencing for NICU babies. We also provide free education and support to NICU providers. We consult with genetic experts. We also do reanalysis, and I'll talk about it a little bit later. And we provide access to cutting-edge therapeutic innovation as well. So it's a pretty large study. I will talk about more than 10 sites now that are working with us. This is our team. And then these are the sites from Massachusetts, from New Jersey, Florida, Texas, among others. So this is a large comprehensive study. We have three major aims. We want to build this study and enroll 250 newborns. We want to facilitate sequencing, create special reports so that clinicians can understand them better, and then reanalyze data. And then lastly, we want to look at the outcomes. These are our inclusion criteria. I'm not going to go through them. You've heard about it. And then these are our exclusion criteria, where we are not going to, for example, sequence or enroll them if they already have a diagnosis or a known family history of genetic disease or other conditions. And this is the workflow. We collect sample, we send it for sequencing, rapid sequencing, and within 5 to 7 days, we get the report from the lab. We create our own comprehensive interpretive report within the next 48 hours, and then that is used by the clinicians, neonatologists, or at the local site to disclose it to the families. And we are there listening in, but we want them to feel empowered to disclose those results. We are also looking into various, and I will talk more about it, but we also do reanalysis as we talk, so that if we don't find an answer for a child, we are going to keep looking because occasionally there may be a new gene or a new pathway that may have been missed that we like to identify. So this is just one example of a case that we had enrolled. This is an infant who was born prematurely, 34 weeks, had an unusually severe chronic lung disease, had some feeding problems, some temperature instability, poor growth, and retinopathy of prematurity, very unusual phenotype for a 34-weeker. So we enrolled the patient, and they found a gene called SRCAP, a variant in that gene that is known to be likely pathogenic, and it was de novo. But if you look at the report, it seems a lot of words which are extremely challenging for neonatologists or any clinician who is not a geneticist to interpret. So creating this comprehensive report helps the clinicians to really sort of know what they need to emphasize. So we created this report where we said this finding is likely of clinical relevance. And this gene, this variant is associated with SRCAP-related neurodevelopmental disorder and considered further clinical workup and then a referral to genetic counselor, geneticist. But we also went through variant information. This variant has been reported with SRCAP-related neurodevelopmental disorder. It's a frame shift causing premature truncation. And then there is a hotspot between exon 33 and 34 in this gene, which is associated with floating harbor, but this variant is not located in this hotspot. And even though the phenotype which we were looking for was lung disease, there is no known association between lung disease and SRCAP. So the underlying cause of pulmonary issues remains unknown at this time. Then we talk more about what to expect. The mutations in this gene are associated with developmental delays, speech delay, behavioral changes, hypotonia, joint laxity. They can also have some micro or macrocephaly and other neurological findings. And then many clinical features may not manifest fully or at all in the neonatal or infantile period. And then we advise them to consider methylation analysis, hearing exam, ophthalmology, neurology, and then also give them with some research opportunities such as simonsearchlight.org as a resource. And then we also tell them that we'll continue to reanalyze the data because we still do not understand why this child has a severe lung disease that needs to be evaluated. So this is a unique part of our study where we are reanalyzing the whole genome sequencing data when the patient has a negative test or a variant of unknown significance. And this is because the only 25 to 40% of families receive a genetic diagnosis, and there are a lot of reasons for that. We still are learning about these genes. There are only 5,000 genes that are linked to human disease, especially rare disease. And then many of them have variants of unknown significance in known genes. And then we also deal with candidate genes where we think that this may be something that may be of interest. So this is one example of a paper we published where we showed that we reanalyzed 102 cases with clinical exome sequencing, and we found that 6 of those 102 patients, we could find the cause of disease in them, and these are the 6 cases by reanalysis. So these were initially diagnosed as negative or unknown significance, and we confirmed that these are truly cause of disease in these patients. And then we noted that there were a lot of them who had variant in candidate genes, which we don't know what it means, but it's of interest for us because this may explain the phenotype. So there were like 15 plus 18 cases, which is 33 cases where we had a candidate gene and we didn't know how to interpret that information. So we looked into that, and 4 years later, 50% of those 33 genes turned out to be disease causing. And this is a lot of work done in collaboration with many labs all around the world where they had more cases, or we did some of the functional analysis. So multiple approaches, and we could explain about half of them to be directly related with the disease. So that's an example of why reanalysis is so important, and not to give up on these cases where you have a negative genome sequencing report or unclear finding. And this is the M3 that we're looking at, like how appropriate this approach is, feasible, penetration, equity, all these goals we have, and the study is still ongoing. And this is just an example of this is early data that we have already enrolled. Out of 250, we have enrolled 193. I think this is a little older number. We are now 200 plus, and our diagnostic yield is about 30%, and further study is being done. And these are some of the publications that have come out from the work we have done on this, and more work is coming out in the future. So I talked about reanalysis, and that ties in nicely with gene discovery. That's one of the goals where we can really do some research into these cases when we are not sure what's going on. This is something I did when I was in Boston, where we built a Manton Center for Orphan Disease Research to really help families with dealing with rare disease. And we had a lot of babies from NICU as well who were enrolled in this so that we can help them find the cause. This is some of the successes we had, more than 750 peer-reviewed publications with this biorepository, many novel genes, phenotypic expansions, and others. So we basically created this protocol where we could enroll these families, collect their DNA, create their cell lines when needed, and also do some functional modeling. This is one of the examples, very first cases we could enroll, and we found a gene responsible for the child who was monozygotic twins with Ohtahara syndrome. And that was our first description of SUN2A mutation to be linked with Ohtahara syndrome. This was published in Epilepsy Journal. So we have gene discovery as one of our goals. We also look at genetic modifiers. We build disease cohorts for genetic analysis. And lastly, we also support development of personalized therapies. And then it's open to all specialties. So this is a very old slide, but it just shows that every subspecialty has a load of genetic conditions that they're dealing with. It's not unique to genetics. It's every type of subspecialty in pediatrics or even in adults is dealing with patients who have a underlying genetic condition. And it can be from cardiology, from neonatology, psych, surgery, endocrinology, neurology, pulmonology, urology. These are just some examples. We have pretty much every type of specialty who has enrolled patients with us to figure out what's wrong with their patient so that we can really find appropriate treatments for them. This is just some data from that study where we had enrolled 2,500 plus families, majority being NF1, and a lot of data generation from different sources. Excuse me. And we have our own pipeline for analysis. And these are some of the genes that we have discovered over the years from 2014 to this year. We have identified 36 new genes or phenotypic expansion. And this work is ongoing. We continue to find new genes. And this is critical to advance this field, to help more families to know what's going on with their child. So it's important work that needs to be done. And then I just want to touch base on what's the utility of sequencing in healthy newborns. So this is an area that is developing. I'm sure you have heard of it. There are many trials going on to understand the utility of sequencing in healthy newborns, coming with a gene list or coming up with because the current newborn screening cannot cover for many conditions that can only be done with sequencing. There is a need for implementing sequencing in healthy newborns as well. So this is work in progress at many sites, but I was part of BabySeq that we did the first study in understanding this. So this is a statement from Francis Collins, who said that over the course of next few decades, the availability of cheap and efficient DNA sequencing will lead to a medical landscape in which each baby's genome is sequenced, and that information is used to shape a lifetime of personalized strategies for disease prevention, detection, and treatment. That was in 2014. I don't think we are anywhere close, but is this the crystal ball that we have been waiting for? We did this study where we looked at the approach of this exome sequencing or genome sequencing in screening newborns. And this is some of the information. I don't think I need to go into all the details, but we did enroll babies and families from well baby nursery and ICUs, and we did report pathogenic, likely pathogenic, highly penetrant variants in childhood onset conditions. We also reported few of the highly actionable adult onset conditions. We also reported carrier status for recessive conditions. And then occasional cases, we also reported VUS when the indication for a disease matches with the gene that was found. We enrolled physicians, primary care and specialists. We also studied the impact of sequencing on families and physicians. So what is the impact on individual and public health? What is the impact on physician and family behavior? what is the impact on the healthcare system? So we wanted to really study what is the utility of sequencing as a way of screening newborns on all these aspects of medicine. So we had enrolled 325 babies, both from the ICU and also from Well Baby Nursery, and we randomized them to either the sequencing arm or the standard of care. And we found that 18 of the 159 had pathogenic or likely pathogenic. So 325 were enrolled and half of them were sequenced. So that is about 159, and 18 of them had something that was interesting. 4 of them could partially or fully explain the phenotype, but 14 of them had some variants that had implications for their care in the future, including the family. So this was the first randomized study of healthy and ICU newborns. We did have some low rates of enrollment, and there was some evidence of anecdotal benefit in few cases. There was a child with biotinidase deficiency, which needed extra biotin as a treatment, and which is also part of newborn screening, but it was borderline. So using sequencing helped to confirm and also treat this patient with biotin. There was one case where family used the information for family planning. The child was heterozygous for a cystinosis variant, and turned out dad also had a variant. So they used pre-implantation genetic diagnosis for their subsequent pregnancy. There was one family where the BRCA2 variant was present in extended members of the family. We also did a lot of ethical and healthy studies, and this study has been replaced by Baby-Seq2 now. So more studies are being done. And this study also was covered extensively by the media, where they said that baby DNA test raises more questions as answers. And then there's a deep dive into newborn DNA, may reveal potential disease risk. But is the testing worth it? So you can see all different opinions. And this has also led to a series of, and this is a lot smaller number of studies. There are almost maybe 3 or 4 times studies that are now going on all around the world trying to address the role of sequencing in healthy newborns. So this is important, and this work is ongoing. So please stay tuned, and we'll hear more about it. And then lastly, I want to talk about personalized therapy. So why are we doing all this? This is the goal, is to really help not only diagnose, but also help these families with treatments. So this was a case that we had enrolled in the Manton Center, and which Dr. Tim Yu is pictured here. He helped develop a treatment for this girl who had a mutation in a gene called CLN7. And this was the whole pathway of time from diagnosis to finding the treatment. And she had a pretty advanced disease, so she did not live too long. But she did have improvement after the treatment was started for a few years, but eventually she succumbed to it. But this is a promise that we are seeing more and more, where this approach or new therapies and new personalized therapies are being developed for N of 1 cases. And NICU is a perfect example of these N of 1 cases where we need to work on not only diagnosing them, but also finding treatments for them. So that's our goal, find treatments. But that starts from diagnosis first. So that's our goal, to diagnose first and then look into treatment. So I built a neonatal genomics program where we had a whole goals that included rapid sequencing, molecular autopsy, reanalysis, integrating with sequencing technologies, functional analysis, integrating with community NICUs, biorepository, and then developing personalized therapies. So these are some of the goals for our neonatal genomics program, and that's how I see how we can advance genomics and help families in the NICU. So overall, I think these are my summaries. Rapid genome sequencing in the NICU provides faster answers for families and can impact treatment and management. I think implementing genome sequencing in under-resourced NICU is critical, and telehealth approach can overcome some of this lack of resources in the NICUs. Educate and work closely with providers to implement genomics in their NICU. So we need to work closely with neonatologists and all the neonatal practitioners in the NICU so that we can get there. And then there are lots of research opportunities as well, where we have shown that reanalyzing genomic data, gene discovery, newborn screening, therapeutics, these are all on the horizon, and we are gonna get there. But I just cannot overemphasize the promise that genomic sequencing offers in the NICU, and I hope that I have convinced you. Happy to take any questions.
Thank you so much, Dr. Agarwal. As a reminder to the webinar participants, if you have a question, please type it in the Q&A box in the control panel. And we'd also like to ask the attendees to take a moment after the webinar has ended to take our exit survey and give us your feedback. And we'll now start the Q&A portion of the webinar. Our first question, we had someone ask, for the Vigor study, do you anticipate additional sites for that study, or how do you select those sites? And
yeah, that's yeah. So we are almost at the end of the study, unfortunately. So we started with 4 sites, and then we added 6 more sites based on. So we want to reach out to places where there is limited resources in terms of genetics or geneticists or genetic counselors. So that's what our criteria was, to really find those NICUs that are remote or they are under-resourced, to have them so that we can test this telehealth model where we can provide them with all the support they need, from finding the right patient to doing the right test to reporting back, empowering them so that they can feel comfortable with reporting those results. And then we also provide them with follow-up options and all, so that they are fully supported. That's the goal.
And the sequencing itself isn't telehealth. The testing is in a lab, but the support element is done through telehealth. Amazing. Okay. And we also had a question about the cost savings. So particularly for symptomatic infants in the NICU, maybe could you share that slide again and sort of go into the savings that you're seeing? I think you said the cost of the sequencing has changed over the years, but.
Yeah, I think that this was a study from California, I think. Let me see where the slide is. But they reported, let me see where the slide. Sorry, this. Yeah, I can't find the slide now, but it should be somewhere. Yeah. Anyway, so this was a study done by Project, I think it was a study from California, where they reported that they found, and the cost of sequencing at that time was like $9,000, and the cost is a lot lower now. So I think the benefits are even higher. Again, we have not done cost-effective analysis ourselves. We are quoting a study that they did. So that's where the numbers come from.
And also for the sequencing itself, to make the decision, sort of the inclusion and exclusion is sort of one of our viewers observed as sort of phenotype driven. So how is it decided what to report versus not report in healthy newborns in your studies?
That's a great question. So healthy newborns is a completely different beast, as you know. We are talking about, there are 2 populations. One is the NICU population, the focus of the talk is on the NICU. But the healthy newborns who are in regular nurseries, there is an increasing interest in trying to figure out we know that RUSP right now, the newborn screening program is mostly based on protein amounts, right? It's based on mass spec. But the genomic side of it can answer many more disorders that have potential treatments. Some of them are already there, and we are not implementing them. So there is a need for at least sequencing for those conditions where there is a treatment available now, because these patients are being missed. from newborn screening because those are not covered. So I think this is a list that is developing. And in fact, there are several studies that are developing their own list. Like some have 400 genes, some have 600 genes. When we did BabySeq, we just did not look at, we just looked at all genes that present during childhood, which have high penetrance, because we don't want to deal with low penetrance genes. We want to only focus on high penetrance and which are only during childhood. So that was a more of a like a proof of concept study, I would say. But more and more, all the newer studies are focusing on a list of genes that needs to be screened for in healthy newborns. So that's the goal of a lot of the newer studies that have started after BabySeq, which was the start of many this approach. But I think that in real terms, we need to come up with a list. And interestingly, a lot of these studies have genes that are there is minimal overlap between them. So more work needs to be done to come up with the guidelines, which are the right genes that needs to be screened. And that is being developed as we speak. And in fact, in state of Florida, we are going to start something called Sunshine GeneDx newborn screening program, where we are going to do this to really, and we are coming up with a list of genes ourselves that will be ideal for these babies which can be potentially treatable and potentially actionable, and things that are that need to be done.
Excellent. I think that leads nicely into this other question we had from someone at the Children's Hospital of Philadelphia who said there's so many different health systems working independently, and this person noted that they have their own big genome sequencing department, but across the river at is another that looks like they're doing something with maybe with your group, and it seems like that perhaps everyone should work together. And is that possible? How would that work?
Yeah, no, this is a great point, and I think that I wish that we all can work together, and there is I think the reason why everyone is doing their own thing is because there is no uniform coverage for these patients. Mm-hmm. So everyone is hanging by a thread to find a place or a project or a study where they can get free sequencing and also get support. So our study was providing that, and Cooper, being an under-resourced place, they joined us. That was 5 years back. But I think that this is where I don't know what's the right answer, because every hospital or every place or every NICU is gonna come up with something that is most reasonable for them and something that works for them or their hospital. Like for example, some hospitals have their own labs, CLIA certified labs, which are doing sequencing themselves. And there are not that many, but there are a few hospital systems who do their own sequencing. And then majority of them are sending to private groups like GeneDx or others, where they pay the cost is covered by insurance or by other means, and they get the sequencing. So the main goal is to get sequencing for every baby. And what's the right? I think, for example, many states have now Medicaid that is covering for sequencing, at least on paper. It is not implemented as well as we would like it to, but at least they're trying that all Medicaid patients should get from the NICU, and even PICU should get rapid genome sequencing on the patients that need it. So that's happening. Most states will join this need, and I think there is clear evidence that it helps at so many levels that we need to work on it. But there's no one solution for this complex problem.
We also had one of our attendees ask the same question about states have passed legislation to cover this for NICU patients with Medicaid. So how do you foresee this impacting the patients by removing that financial barrier?
Yeah, I will say I can also already see the change. So when I came to Miami, I can already see that we can have more cases that are being covered by the state for rapid genome sequencing. And I think this awareness of it and like jumping through the hoops of, barriers, because whenever we try to start something new, and which is, there will be a lot of barriers from administration, from even though state covers for it, that's administration and the neonatology, and everyone has to come together to say this. We need to take advantage of this. This is available, state covers for it. What is holding us to not use it? In fact, I visited Tallahassee one time that this same question was raised. Why, even though we are covering for it, why there are so few genomes being done in the state? That was a big question being raised on the floor. So clearly there is a gap between what should be done and what is being done.
Is it, you probably, it's multiply determined, but is any of it from like the patients or the parents not wanting to participate, or is it more just sort of a bureaucratic question?
So yeah, that's another thing that we have to deal with is the consenting process for families. And sometimes those processes can be scary. And many families sort of, when they hear the risk of like getting that information out, or insurance companies, even though we have rules, they can still get out of that. They get very nervous, appropriately so. So not a large number, but definitely a significant percent of them do back out. It's like in our study, it was much better because we were like, when we did our study, most of our families agreed to participate. But I know that this is a barrier. I've seen it firsthand where families are like, oh, we don't want to, because also there is a lot of scare from so many directions that there is definitely a lot of misinformation about genomic data as well. That doesn't help our cause. So yes, but majority of the families still go for it because of the need for a diagnosis.
Yeah. Okay. And we had an attendee who is a genetic counselor and wanted to know if you work in a system without access to a geneticist, do you have any advice for trying to increase testing in the NICU for someone in that situation?
Yeah. So I think it's going to be multifold. One is that I always say that we need to find champions within every division. Every NICU should have a champion who understands genetics, the utility of it. Like I remember when I started first doing this test, people said, okay, we will have a name for the genetic condition. What's the big deal? Like, you will have a name for the gene. That's all. So, and then when they saw it firsthand, how in so many ways it impacts the families, including like sometimes the families blame themselves for their child's condition. And once they have a genetic diagnosis, they know what exactly happened or how did it happen. And that gives them a big sigh of relief that at least we know what happened. And then they can use it for family planning. A lot of these families use that. And then there are treatments for many of these conditions. There will be more treatments coming. As we know, many drugs are being developed for these rare and ultra rare conditions. And unless we diagnose them early, these patients will not be able to will have the benefit of these therapies. So like I showed the example of this one case where a drug was developed, but the diagnosis took a long time. And she was already in a very severe disease stage where it almost became irreversible. So that's another thing we have to deal
with. Okay. We had a question about methylation analysis. Someone had a patient with unremarkable, unrevealing whole genome sequencing, NWES, for example. Only when they did methylation did they find the answer. Is that something that sort of these next levels of analysis for these babies?
Yes, and that's a great question. And I think that as technology moves forward and long read sequencing, that also includes methylation, becomes part of mainstream sequencing. This additional test won't be even needed. We can have that in combination with sequencing. But that's the whole point. Like if you don't find an answer by sequencing, don't give up. you have many other approaches. You have reanalysis, you have methylation, you have transcriptome, you can look into proteome, but all this needs research. Majority of them need research as a way to get there. There are some methylation chips available clinically, and they are being used as well in select cases, but I still think that is underexplored at this time. As we learn more and more about methylation related disorders, more knowledge will be earned, and we'll be able to diagnose them. And I think long read is going to make a big difference as well.
Excellent. We had another question about a specific one about in one of your slides. Slide 43, you mentioned the limitations of analytical methods.
Yes.
Yet there's a wide gap from lab to lab in bioinformatics and analytical capabilities. And so what is your selection criteria for selecting the best available analytic capabilities?
So that's a great question. Like, what's the right approach once you have a negative genome or a genome where you found some variant which you don't understand? And that's where I think having a team that, like we have, as I said, we have our own pipeline we use. We have developed in-house in our lab. It's run by a bioinformatician who is a PhD in math who developed it. And we have shown many cases where that reanalysis approach has helped several families. So I think we need to develop these type of expertise in hospitals or collaborate with hospitals where this type of expertise exists, or they have a focus on this type of expertise, like we do have. And there are other institutions like Broad Institute in Boston. There are many others that are doing this type of work. So I think that we cannot not try to keep finding answers for these families, especially where we strongly feel that there is something underlying genetic and sequencing has not found a cause. We have again and again shown also like long read sequencing can help, transcriptome can help, or like every time we do a new level of testing, it can resolve another 5 to 7% of cases. So it's not a big number, but it's worth trying to not to keep trying to try different approaches.
So fascinating. I mean, on like the diagnostic side, when you're talking about like infectious disease, you say like, well, you know, maybe you don't want to run this test if there's no treatment, you know, but in your case, you have like this different time scale where you know, your patient has their genome forever. You can always reanalyze and the technology changes. So interesting. Someone actually was just asking, would you use RNA-seq to gain additional insights? And
yes, we do use transcriptome as well, and proteome too. Lately, more and more proteome can also give us some clues about diagnostic insights into what to look for. So yes.
We had one of our attendees ask about if a patient had, or do you see this sequencing like replacing prenatal testing somehow, or like in the distant future, I would assume that.
Yeah, no, for sure. And in fact, we are trying to do a study where we want to use whole genome, rapid whole genome in prenatal samples, because when there is a suspicion for a genetic condition, is it worth waiting till the baby is born, or can we diagnose them sooner so that we are better prepared, or the families are better prepared and we are better prepared for what we are going to deal with? And as you know, sometimes it may be a condition which is going to have a devastating outcome. Is it worth continuing that pregnancy, or is there? I think knowledge is power. If we can diagnose them sooner prenatally, I think we should, because it will really, in so many ways, and now more and more we're talking about fetal therapies, fetal gene therapies, and new things that are coming. So I think that we need to extend it to prenatal time as well.
We have time for maybe a couple more. We had a question about managing the capacity, like at the geneticist level or genetic testing level, are these people getting overwhelmed?
You mean the geneticist or
It
who is
the
getting
question
over?
was about the geneticists. I'm wondering about the
Yeah,
labs and the yeah.
yeah, yeah. I think that do have an adequate number of labs who can do it, and we're doing a great job, including GeneDx, where we have done a lot of work with them over many years. And I think the bottleneck can be like finding the right patient, who's the right patient, who's going to disclose the results. There are all these bottlenecks, and then who's going to cover the cost. Those are the things that I think is a bigger issue. And as you know, there are a limited number of geneticists and limited number of genetic counselors. They are definitely overwhelmed, and there's need to grow. There is a need to grow these programs, genetic counseling and geneticists, and also empowering other clinicians, including neonatologists, for example. I think we need more champions from neonatology who feel comfortable. Like we have neonatologists who are great in like reading, like taking care of babies with hypoxia. There are neonatologists who are great with treating lung disorders or extreme premature babies. How about having neonatologists interested in genomes? I think that's an area that we need to develop and grow so that this this uh, this approach of taking care of newborns can be shared, and those hospitals can implement these approaches sooner rather than you know having these families suffer through a delayed diagnosis or dealing with prolonged diagnostic odysseys.
Yeah. I mean, that seems to be the theme, right? That
Yeah,
reducing the
yeah,
suffering. And when you showed the
yeah,
floppy baby, I was like, oh
yeah,
my goodness. You know, like,
yeah.
it would be really helpful to have some kind of an answer in these cases.
Yes,
So,
yes, yeah. And
um,
I've seen it firsthand myself as a neonatologist, but as a fellow, that it took us months and months to really not even then getting to a diagnosis, and now within 5 days we can have an answer. It's a sea change in care for many of these conditions, but especially hypotonia, seizures, multiple anomalies, and all that. Yes.
maybe one more question we had. Do you feel like the variation in interpretation between different sequencing efforts, um, could there is there a significant variability between like different centers?
Yes, I think there is definitely variability in the quality of the data. Like every time we get data for reanalysis, for example, we look at the data ourselves, the quality wise, like how is the depth of coverage, how is the like a lot of things, and we saw a lot of variability. We see a lot of false positives in sometimes, and that's why it's very important to work with a lab that has a lot of experience because they are the ones who have done it a lot. They also know how to interpret the information. It makes our job a lot easier. So if there is like, if you have 10x coverage of 70x versus, if your 70% of genome is covered with 10x versus 95%, big difference. And we see that all the time. Like there is quality differences all the time. So there's batch effect, there is company related effects, there is platform effects. So I think that's why not all genomes are created equal. It's not like doing a hematocrit or electrolytes. It can be very highly variable.
In the last few seconds, one more about what is there liability in not testing?
Yeah, I wish there is some liability in not testing. There is. I don't know of one, but maybe that's one way to do it. Is that
Mhm.
more and more families are gonna say why there was a delay in my child's diagnosis, and then take the clinicians accountable or hospitals accountable for the
Mm,
delays, and that may expedite these. That's a great question. Yeah,
amazing. Okay. Um, that's all the time that we have for today.
yeah,
We'd like to thank
yeah.
Dr. Agarwal and our sponsor, GeneDx.